Okay, hello. This is your virtual gynecologist from the Artificial Intelligence Medical College, and I'm actually going to take you through pelvic inflammatory disease, that is PID, one of the most common infections that females face. And I want to take you through this lesson. If you are the medical student or you are a person and you want to know more about what PID means, this is the right channel and this is the right person. This is a virtual gynecologist from the Artificial Intelligence Medical College. So pelvic inflammatory disease, the definition: it is an infection ascending from the endocervix to cause endometritis, salpingitis, and parametritis, ophoritis, tubo-ovarian complex, pelvic and generalized peritonitis. In simple terms, it is an infection that starts from the inner vagina to extending to the cervix, and it is always a very serious infection because it comes when you have not treated the STIs, and the infection spreads from the lower to go to the upper cervix, and if not treated, it has very, very dangerous and very catastrophic effects, causing an example, it causes infertility. So it is an infection that may involve the uterus, the fallopian tube, these ones, the tubes, the ovaries, and the pelvic cavity, and may produce tubo-ovarian abscesses. So it is a very serious infection. It starts from down here in the labia minus to the upper side, even reaching to the tubes, and if you go untreated, it may block the tubes, may cause ectopic pregnancy, whereby the pregnancy will be in the tubes, and you risk infertility because you may never have a chance to conceive again. What are the factors that exposes the patient or you as a person to this? When you have multiple sex partners. Another one, when you use non-barrier contraceptives like IUDs, non-barrier contraceptive methods, all the other non-barrier the barrier contraceptives are the condoms, those that prevent the sperm from entering. So the IUD is a non-barrier. The injections, the pills, they are non-barrier contraceptive methods. Another one, the predisposing factor, instrumentation of the cervix and uterus. Another one, the recent menstrual period. The recent menstrual period can be a cause of PID in case the blood did not completely leave the system. Current STD infection. When the STD goes long untreated, it extends to the upper side of the uterus and causes PID. When you have a history of PID, when you had the previous one and you didn't treat it very well, you can get that it can be a starting point for the next PID. Dodging. Most women prefer to use soap and other things to clean the vaginal area, which is not good and not medical. So you have to leave clean only the outer side, because the internal side has its own way of cleaning itself. That is what we call dodging. Most people use soaps, use perfumes, but that is not advisable. So PID, microbiology. That is, we are looking at what are the causing germs, the microbes that bring that PID? We have chlamydia and gonorrhea, especially the N-gonorrhea. Then we have mycoplasma species, we have the anaerobes, we have the cytomegalovirus, we have the Bacteroides Streptococcus and Streptococcus species. We have E. coli, that is the bacteria, and Haemophilus influenzae. So actually this PID is mainly bacteria caused. This harmful bacteria spreads to the uterus, to the tubes, and causes catastrophic damage. The clinical features of acute PID, that is, if it has gone to the acute level, meaning it has grown completely, we have bilateral lower abdominal tenderness, we have abnormal vaginal or cervical discharge, about 75%. We have fever greater than 38 degrees Celsius, that occurs in 30% of the people. We have deep dyspareunia. Then we have cervical motion tenderness. When you observe, you see the motion. We have adnexal tenderness and adnexal masses. Then we have abnormal PV bleeding. It occurs in 40% of the women. These features lack specificity and sensitivity, so it always happens. It is the percentages. These are some of the features. If you are a clinician and you are observing a person, you can conclude that is acute. Or if you are a person and you are reading, you want to know about yourself, you see these features, you better know it has reached in the acute side. So, investigations to assist in making diagnosis. One, if you are a clinician, they make checks, and if they find the white blood cell check and they find you have 10,500 white blood cells greater than in 1 millimeter cube of blood, then you know you have this PID, because these white blood cells are there to fight the foreign bodies, and there they know exactly you have this kind of thing. We have erythrocyte sedimentation rate. This one, how do we do this? We get the distance the red blood cells travel in 1 hour in a sample of blood as they settle to the bottom of a test tube. So we get the blood, then we measure the distance the red blood cells travel in 1 hour in a sample of blood as they settle to the bottom of a test tube. The sedimentation rate is increased in inflammation, infection, cancer, rheumatic diseases, and disease of the blood and bone marrow. So this is what we call erythrocyte sedimentation rate. So when you find these red blood cells are sedimenting at a higher rate, you know you have a very high inflammation. We have endocervical swab. Here we have to get a swab of, we get some cells on the cervical side and we culture them and we examine, and we get out the seriousness of the disease. Rapid assay for chlamydia, we test for chlamydia, the rapid test. So we have the pregnancy test. appropriate cultures, the urethra, the blood, and peritoneal fluid as indicated. So we can get all those fluids and we test for this thing, but mainly we can use the scan, laparoscopy, and we check if there is something on the uterus there. We check if there is something here on these walls. So differential diagnosis, we have appendicitis, ectopic pregnancy, endometriosis, hemorrhagic corpus luteum, that is if you're bleeding. We have adnexal torsion, mesenteric lymphadenitis, pyelonephritis, then other intra-abdominal processes. Pelvic inflammatory disease classification, we either classify it as acute, chronic, and acute on chronic. We use the Gainesville classification, whereby the grade 1 is considered acute salpingitis and no peritonitis. Grade 2, acute salpingitis with pelvic peritonitis.
Viani agenda kulu no mukwano gwo.
And we have salpingitis is the inflammation of the fallopian tubes caused by bacterial infection. So if you have not been knowing what salpingitis means, it is an inflammation of the fallopian tubes caused by bacterial infection. Common causes of salpingitis, we have say STIs, just gonorrhea and chlamydia, and it is a common cause of infertility and can damage the fallopian tube. So grade 1, we have acute salpingitis, that is acute inflammation of the fallopian tubes and no peritonitis. Grade 3, acute salpingitis with tubovarian complex. Pelvic peritonitis, I can tell you what peritonitis means. Peritonitis. So peritonitis is the redness and swelling of the lining of your belly or abdomen. That is peritonitis. The lining is called the peritoneum. This lining of the abdomen and belly, it is called peritoneum. So if it is red, that is called peritonitis. Pelvic, if you find the pelvis is red and swollen, that is peritonitis. So ruptured tubular ovarian mass with generalized peritonitis. Treatment. Because of the risk of infertility, treat all patients with PID presumptively while awaiting the cultures. Yes, because PID, you risk being infertile. What you have to do when you examine and you see the symptoms are of this, as you await the cultures from the lab, treat presumptively. What does something like presumptively? Let me see the called the thing presumptive. Presumptive means presumed in the absence of further information. When something is presumptive, presumed to have occurred, that is something presumptively. Presumptively, that is absence of further information. So you immediately give treatment as you await the cultures. Outpatient therapy, the temperature is not high. If the temperature is not high, you specify outpatient, you don't admit. Minimal signs of peritonitis, active bowel sounds, able to tolerate PO, good compliance is likely. Treatment in outpatients regimens. We normally give oral ofloxacin 400 milligrams plus metronidazole 400 milligrams, and they take them for 14 days. We give them tabs for 14 days. Another treatment, we give them ceftriaxone 250 milligrams intramuscle. It's an injection, plus oral doxycycline 100 milligrams twice, and metronidazole 400 milligrams daily for 14 days. Number 3, treatment 3, we give them cefoxitin, doxycycline, and metronidazole. Another treatment, this is a weak clinical trial evidence. In case they are just starting, we give ceftriaxone 250 milligrams intramuscle and erythromycin 1 gram per week for 14 days. Inpatient therapy, suspected abscess. In case we suspect there is abscess, there is a mass that formed inside, he has high temperature, is unable to take the medicine, and is having peritonitis, severe redness of the pelvis and swelling of the pelvic, we give that. No response to oral antibiotics within 48 hours. No compliance to treatment and follow-up. If you've given him the previous treatment and he doesn't respond, then you have to consider inpatient therapy. The aims, we give bed rest, we do IVF to correct acidosis and dehydration, intravenous, we give the intravenous, and with abdominal distension or areas, we insert NGT. I have to make you familiar to the medical terms, though I'm a virtual doctor. NGT is called nasogastric tube. If the person is not able to eat, we have antibiotics, exploratory laparotomy if condition worsens, and then we do continuous evaluation. The drugs, we do ofloxacin intravenous plus metronidazole intravenous, then the doxycycline or clindamycin for 14 days, or we give ampicillin intravenous, metronidazole intravenous, and gentamicin, then oral amoxicillin and metronidazole. Management of sexual partners, because this thing is all about having sexual partners, having untreated PIDs and STIs. So how do we manage this? We do sexual partner tracing and screening. We screen them for gonorrhea and chlamydia, and we advise you to avoid sexual intercourse until both the patient and the partner have been treated. We do empirical treatment of partner for both chlamydia and gonorrhea. Complications, we have acute complications, acute on chronic pelvic inflammatory disease. We have rupture of the tubo-ovarian abscess. If you have a mass in the tubes and of ovary and it ruptures, that is a complication. I've had an torsion. Torsion is something like twisting. That is twisting. Yeah, twisting of the state being twisted. So you have the adnexal twisting, we have septicemia. Long-term complication, we have dyspareunia. Dyspareunia is a medical term for painful intercourse. If you have painful intercourse, that one we call it dyspareunia. This one you can know it even if you're not medical. When you have severe painful intercourse, just tell the doctor, I have dyspareunia. It is a way of avoiding saying some words that are not easy to speak in public. So as a virtual doctor, I'm just telling you words so that you actually can easily speak medical terms, or if you are still a young doctor or a young medical personnel, you can know the terms that are within your field. As me, I'm a virtual doctor and I'm not supposed to deal directly with the people. And we have something called dysmenorrhagia. Dysmenorrhagia has to deal with pelvic, with cramps. You have painful menstrual periods. Painful menstrual periods, dysmenorrhea, painful sexual intercourse, dyspareunia. Then complication of long term, you may have infertility, 50%. Then you have chronic pelvic pain. This is experienced by 25 to 75% of the patients that get PIDs, and 50% of the patients who have PIDs that are untreated for long, they get infertility. So that thing is very serious. You imagine you are a wife and you're going to have dyspareunia for the rest of your life. You don't expect to stay with your husband, because you can't have painful sex for the rest of your life. You have to quit and you remain there single. So you have to treat this. When you notice any signs of PID, rush to your medical personnel. I'm just giving an awareness. Chronic pelvic pain. Then some experience 7 to 10. We have ectopic pregnancy. Sometimes 7 to 10 of the people that get this stuff of PID, they get ectopic pregnancies, and ectopic pregnancy is one of the worst pregnancies you can have, because you're risking your life. You're risking the mother's life, risking death, because if not detected, you are in serious trouble. We have long-term complications, tubal obstruction, secondary to adhesions. Tubal obstruction. You risk having your tubes obstructed for the rest of your life. Actually, that is what causes the infertility, because your tubes are blocked by the abscesses, that by the masses that form inside the tubes, and you will lose your childbearing ability. Increased risk of ectopic pregnancy. You see something like this, the baby is forming in the tubes, which is not good. It's not really good thing. And there goes the end. I do a recap because I don't want you to suffer from this disease, because it is very dangerous to you and your partner. I want you to know, when you feel something, when you have abnormal vaginal discharge, especially the yellow discharge, and it is having a very fishy smell, just run to the doctors. If you have fever may not come because it comes at a later stage, but once you notice you have normal vaginal discharge, actually my advice to all women is to always check the smell, the odor of your vaginal fluids. If you get abnormal bleeding, that is not during your periods, you know you have this stuff. And I wish you all to not to suffer from this thing. If you get it, let it be treated at the start and avoid the factors that predispose you having multiple sexual partners. Make sure you have one partner, and if you have multiple, use barrier contraceptives like condoms that prevent the infections from spreading. And when you get an STD, when you have an STI, make sure you treat it. If you had a PID that you were on treatment, after 1 week after treatment, please go back and they examine you if it is still there. Douching, avoid using water to clean your vaginal area. With those, I remain your virtual doctor, the virtual gynecologist at the Artificial Intelligence Medical College. Thank you. Good day.